How's it going, guys? We have a challenging question for dermatology. 83-year-old man, routine health maintenance examination. Laboratory studies show bleeding time upper end of normal at 7 minutes, should be 2 to 7 minutes. PTT, normal 36 seconds, should be 25 to 40 seconds. PT, normal 13 seconds, should be 10 to 15 seconds. Past medical history, otherwise unremarkable, no medications. His right wrist is shown. We have what appears to be a purpuric or ecchymotic lesion here. Which is the following most likely explanation for the patient's findings? Choice A, antibodies against glycoproteins 2B3A is wrong. This is the mechanism for ITP, idiopathic/immune thrombocytopenic purpura. Now, our patient doesn't have an elevated bleeding time. It's upper end of normal, but it's not elevated. So in ITP, you're going to have an isolated increase in bleeding time, and your platelet count will be reduced. Only about 50% of questions will mention a preceding viral infection for ITP, but it's usually viral infection followed by the formation of antibodies against glycoproteins 2B3A for platelet aggregation. 4 out of 5 questions will be a school-age kid who has epistaxis, nosebleeds, and petechiae, skin lesions. And 1 out of 5 questions will be a woman 30s to 40s with random bruising who's got an elevated bleeding time and low platelet count. If her labs are normal, you want to think about domestic abuse instead. Wrong fucking answer. Choice B, acquired factor VIII deficiency. Wrong fucking answer. So this can be seen idiopathically in patients over the age of 60 who are male. However, you would have an isolated increase in PTT, and our PTT is normal here. Okay, it can sometimes be seen postpartum women. So the formation of antibodies against factor VIII. This is different from hemophilia A, congenital deficiency of factor VIII, where they receive repeated aliquots of factor VIII for treatment, and they develop antibodies against factor VIII. And those antibodies are called factor VIII inhibitor. So you could think of that as an acquired type of factor VIII antibody, but that's different from acquired factor VIII deficiency, which, as I said, is idiopathic autoimmune, usually in males over 60, or it can be in postpartum women. But you'd have an isolated increase in PTT, which we don't have here. Wrong fucking answer. Choice C, cryoglobulinemia is wrong. So a cryoglobulin is an immune complex that deposits at cooler temperatures. And on USMLE, you're going to see this in the setting of hepatitis C or malignancy, which we have no past medical history here. So you can get these immune complexes depositing at cooler temperatures in the microvasculature of the skin, and you can get purpuric lesions like you have here. Okay, and you can get serum C4 decreased, complement protein C4 decreased, very high yield for cryoglobulinemia. And why you know it's a type 3 hypersensitivity because it's immune complexes. Okay, wrong fucking answer. Choice D, leukocytoclastic vasculitis. For both sounding answer choice is wrong. Okay, so leukocytic vasculitis equals palpable purpura secondary to immune complex deposition in superficial vessels of the skin. Now, cryoglobulinemia with immune complexes depositing in superficial vessels is a type of leukocytoclastic vasculitis, cryoglobulonemic vasculitis. But leukocytoclastic vasculitis is a broader umbrella term. You can also have henoch-Schönlein purpura, aka IgA vasculitis. That is also a type of leukocytoclastic vasculitis. Usually pediatrics, they have a viral infection, and then they get palpable purpura, immune complexes, IgA, immune complexes depositing in superficial vessels of the skin, causing palpable purpura. You also get IgA nephropathy, so hematuria. 1 to 3 days following the viral infection, you get abdominal pain and arthralgias. Wrong fucking answer. Choice C, solar elastosis. Correct answer. Elastosis means sun damage. USMLE will use the term. Diagnosis is actinic purpura, aka senile purpura, and they'll give you a picture just like this on USMLE, and the answer is just senile purpura or actinic purpura. You need to know it's a benign finding. Over many, many years, as in your whole life, sun exposure can lead to degradation of the underlying dermis and collagen. And that can lead to friability and increased proclivity for microvasculature bleeds in the skin, okay? Bleeding on the microvasculature. So it's not a platelet problem, and they just want you to know that solar elastosis, sun damage, is the mechanism for actinic purpura / senile purpura, no treatment necessary. Correct answer.